Special thank you to Sanford Burnham Prebys Medical Discovery Institute, as always, for letting us use this auditorium. I would like to introduce the principals of the organization that hopefully you all know well by now. We have Bill Lewis, our president, sitting here in the front row, usually outside helping to set up everything, making sure the meeting runs so well. Getting to enjoy Dr. McKay's talk today. We have Gene Van Vliet, who could not be here today. He's our director and treasurer. Steve Pendergast, our secretary and newsletter editor. Bill Manning, our director and videographer, as well as Patrick Espinoza, our videographer here today. Myself, Aaron Lamb, director and facilitator of the meetings. John Tassi, our webmaster. Bill Bailey, our librarian. And of course, there's you. Well over 900 members. Everyone can be a volunteer, and you can too. How many newcomers do we have today? Apparently quite a few are here. Hopefully you've all received a newcomer packet as you walked in the front door. There is a cover sheet. Please return that to me either up here at the podium. There's a pile that started on my bag here in the front row that gives us your contact information, so you'll be on our mailing list, as well as it gets you a hotline call from either Bill or Gene or myself in the coming week to see how best the organization might be able to get you the information that you need. Our support to you comes in the way of our website, www.ipcsg.org. You can also find recordings of all of our YouTube videos. YouTube.com/prostate cancer support is our channel. The meetings, of course, are on the third Saturdays of every month, but not in December. And you can get our newsletter either on the website, by email, or by physical mail if you so request it. We also have the hotline number. This is the hotline number for Bill. I know many of you that might have had a recent diagnosis, have a lot of questions, are really looking for somebody to just help you get started on this journey. This is the number that you call to get you started. I want to take a special moment to recognize and thank Bill Lewis for everything that he has done for this organization. I am embarrassed that I did not prepare something proper. As you may know, he's moving to Utah to be closer to his kids, and that has a significant impact on all of us, really. I can't even begin to tell you everything that this man has done for this organization. All right, it is as great as it is because of him, and we have some shoes that are now going to be empty that we need filled, and we need volunteers to help out with. Bill, can you please stand up for a moment just so everybody can give you really, I want a standing applause for this man. Yeah, and as I said, I'm embarrassed. I've been way too busy the last couple of weeks to come up with a proper way to appreciate Bill for everything that he's done. I wanted to get him a cake, get him a fruit basket, I mean, whatever it was. But, many that might know of my situation right now, I barely have a minute to spare, unfortunately. So thank you, Bill. Thank you very much. And thus, we have a call for volunteers. Bill has done a lot of work in this organization, especially for signing up meeting guests. Now, I believe we've had one or two people that have given their names in to help out with this. Please, before you leave today, we need the names, contact info of you to help out with this. I'm serious. We actually don't even have a speaker set up for next month. We just need your help. And I think, John, you were going to be helping out a little bit with this, but if there's anybody else, we need your help, all right? Like I said, I'm down to the minute on now being a sole caregiver for our daughter, it's a very difficult time for me, myself. We are looking for people to basically shadow every principle of the organization. We need somebody with not necessarily accounting experience, but somebody who can look over the bank account once in a while. We're not asking for anything more than an hour or two per month for doing that type of job. Please talk to Jean. We need somebody to help out with this. I need a backup meeting facilitator in case I have to step out. Luckily, my surgery is probably going to be in December, so we don't have a meeting then, but there might be times where I'm not going to be able to make it. So please come talk to me. We'd like somebody to shadow Stephen with the newsletter so that they're familiar with everything that he does and can help out, whether it's proofreading, whether it's editing and putting together the newsletter. Please talk to Stephen, talk to us, as well as taking hotline calls. So this organization only works so well because of the volunteers, and we do need your help. I want to note the upcoming Prostate Cancer Patient Summit that UCSD is putting on. It is January 31st and February 1st. Website there you can see up here. I'm sure that you can Google it and find that link as well. Excellent, excellent meeting. Dr. McKay, the whole radiation oncology team, so many UCSD doctors will be there. I have heard a rumor that there's going to be a very, very big speaker this year, so not to be missed. I highly recommend registering and going. I'd like to take a minute to remind you all of our support group purpose. We share patient-focused experience on being your own case manager through informing, networking, and caring. We are a group of experienced participants, but we are not medical professionals, and any sharing by anyone of our group may not be a substitute for your medical counsel. And we do need your support. Can I get someone to pass around the baskets? We are a 501c3 nonprofit organization. Your donations are tax deductible. There's no medical or religious affiliations, and our largest costs are the website, advertising, mailings, getting this information out to everybody. Please make a donation. If you don't have cash or check today, you can make an online donation via PayPal. That link is on our website. You can also mail a check to the P.O. box address that you see there. And take a moment to think about what a fantastic speaker we have today in Dr. McKay. Many of you, your insurance doesn't actually allow you to visit this doctor yourself, and just the information that you get from her today, think of the value of it, and please consider that when making a donation to the organization so we can continue to bring in fantastic presenters like Dr. McKay. And so let's turn it over to Dr. McKay. She's going to be speaking today on the latest in prostate cancer treatment. As you likely know already, she's a medical oncologist, associate professor of medicine with UCSD Department of Urology. So with that, Dr. McKay, please take it away. We're going to have a hard stop right around 11 o'clock, so please save your questions until the end. We'll have a few minutes for Q&A. So thank you, Doctor.
Well, of course, thank you so much for that wonderful introduction, Aaron. And I just want to say thank you all so much for all that you do for the community, for all that you do for patients, being a voice for the needs and advocacy of our patients. And I can't even express enough, Bill. I know you're in the room, and I wish I could be there with you, and I wish I could be there giving you a big hug right now in the room. You have done so much for this community, and you've done so much and with prostate cancer and caregivers of those individuals with prostate cancer. You are irreplaceable. You're a giant in this community, and you are going to be sorely, sorely, sorely missed. Fall, we have a very large meeting where we get updates on new things happening across multiple malignancies. There's an annual meeting called ASCO. You guys are all familiar with it. It happens over the summer. Second largest meeting happens in Europe in the fall. And just a couple of weeks ago, that meeting occurred, and I thought it would be really timely to give you guys updates. So we're going to dive right in. This is updates from the ESMO meeting, which is the second largest oncology meeting in the world annually. It just happened a couple of weeks ago, and I thought it would be very timely to go through updates with you. Next slide. So just so highlight the learning objectives, we're going to go through the current treatment paradigm for metastatic hormone-sensitive prostate cancer. We're going to talk about when to use doublet therapy, when to use triplet therapy for metastatic hormone-sensitive disease. We're going to talk about some new treatment options for hormone-resistant disease, and then we'll end a little bit on clinical trials. And I'm going to try to make sure that we get through this in about 30 minutes. I may go a little fast in some sections just because I want to make sure we get to questions. All right, next slide. So starting off with metastatic hormone-sensitive prostate cancer. Next slide. We know that many men present with prostate cancer. Most individuals actually present with localized disease. And a large portion of those individuals are actually cured with surgery or radiation, with or without hormones. But a subset of individuals go on to develop a recurrence, and some of those individuals develop metastases. There's also some individuals that at the time of diagnosis, they actually have metastatic disease. And our treatment paradigm for patients who have metastatic hormone-sensitive prostate cancer has really changed over the last decade. A decade ago, we used to only use hormonal therapies to treat this disease. And many clinical studies have demonstrated that people live longer and live better actually by intensifying therapy in the metastatic hormone-sensitive setting. And what I will say is treatment intensification for people with metastatic hormone-sensitive disease is the standard of care now. And people can never catch up from an overall survival standpoint when they don't get intensification when they have metastatic disease. Now, keep in mind, this definition of metastatic disease was defined based off of conventional imaging, because many of the studies that were done were not done with concurrent PSMA PET imaging. So what I'm talking about here when I say metastatic disease, it's metastatic disease using normal CT scan and bone scan. It doesn't necessarily mean metastatic disease that's identified with a small spot on a PSMA PET scan. That's not what we're talking about here. That's a different entity that we won't go into too much detail there, but certainly happy to answer questions. So we classically break down metastatic hormone-sensitive disease into 4 buckets based off of how much disease we see and when the disease came on in reference to that individual's diagnosis. And these 4 buckets of high volume de novo, high volume relapsed, low volume de novo, low volume relapse really help us with understanding what our treatment strategies should be. People that do the best are those people that have low volume disease, that initially were diagnosed with prostate cancer that's localized and then ultimately ended up recurring. Those people do the best, and I think there are strategies to consider de-escalating therapy for those individuals, but the current paradigm is ADT with a hormonal agent. But for individuals that are not in that category, there's clear and robust data for doublet therapy, and in some situations, triple therapy with the addition of chemotherapy. Next slide. So one of the big questions when we have patients with metastatic hormone-sensitive disease, now that we have data that giving 2 drugs is better than 1, and when you're using ADT chemo, giving 3 drugs is better than just ADT chemo. So one of the biggest questions we encounter clinically is who should actually get chemotherapy when they have metastatic prostate cancer? And there are certainly prognostic tests that inform how people do, but predictive tests to actually guide who should actually receive a therapy have been a little bit lacking. If we go to the next slide. So there was data that were presented at ESMO just a couple of weeks ago that utilized the Decipher test to actually inform the concept of treatment intensification and who should be intensified based off of their Decipher test. Now, the test the study that looked at this was called the Stampede trial. You all may be familiar with this study. And Stampede enrolled a very, very large number of patients, almost 4,000 patients. And this was in the first phase of the Stampede trial, where they were just using hormonal therapy and hormonal therapy with chemo. And what they did was they tested all of the patients' tissue from their prostate, not all of them, but a subset of them, the ones who had tissue available, and ran the Decipher test on all of these patients up front to see if it could be prognostic or predictive. Let's go to the next slide. So what we demonstrate here is actually that the Decipher high score was predictive of potential benefit to docetaxel. You could see in this graph on the right or on the left that those that had a high score actually did better with chemo. They had a survival advantage with chemo. But those with a low score, the chemo didn't really seem to change their outcome. Now, this data is still hypothesis generating. We haven't validated this test. And this study didn't look at the addition of the oral hormonal agents. But this data is incredibly provocative and kind of opens up the door for a predictive test to guide utilization of chemo for metastatic. This is hormone sensitive disease. This is not late stage disease or castration resistant, but this is people who are kind of newly diagnosed with metastases who should get chemo or not. So I thought this was relevant to share because we don't really think about Decipher in the metastatic setting. It's probably something you all have looked at in the localized setting. And I think additional studies are going to inform how we use this test. Next slide. The other study that I wanted to highlight is this study called Upfront PSMA. So this study was really interesting. You all in the room are probably familiar with lutetium PSMA. It's a targeted radioligand therapy. What that means is it has a little bit of the molecule has a little bit of radiation on it, a beta emitting radiation. It has a linker, and it's bound to a small molecule that binds to PSMA. And this drug has now been FDA approved for people with late stage disease that is refractory, it's post chemo, it's post hormonal therapy. It's approved in that setting. And to receive it in the clinic from an insurance standpoint, most patients have to have had chemotherapy, or it's kind of an uphill battle to fight to try to get patients who haven't seen chemo this drug. There's data from one study called PSMA-4 that is trying to move this up, but this study actually looked at use of lutetium for people with hormone sensitive disease. So not castration resistant, their disease hasn't progressed on hormonal therapy, but really even upfront. And it was done really interestingly. It was de novo patients, metastatic disease up front, high risk, and they gave patients 2 doses, only 2 doses. Usually when we use this drug, we give up to 6 doses. But on this trial, they gave 2 doses of lutetium, spaced out 6 weeks apart. And then when they completed the lutetium, patients went on to get chemotherapy. And the trial was randomized. Some group, half the patients received the lutetium, half the patients didn't. Next slide. And what we see, I know this is a lot of data up here on this slide, but what we see is this was a smaller study that didn't really look at overall survival. But when we look at week 48 PSA, the people that got the lutetium, the likelihood that they had an undetectable PSA at week 48 was 41% compared to 16%. And the percentage of people that had an undetectable PSA at any time point was over 50% of patients. So this was a very provocative trial. There's a large industry trial that's currently completed accrual called PSMA Addition that's going to more formally answer this question of the use of lutetium for metastatic hormone sensitive disease. But from this trial, we see a signal of activity of this agent much earlier on in the game. So this could be something that I think in the next couple of years may be available even for people with newly diagnosed prostate cancer, because right now we're using it very late stage. Okay, next slide. So just as a summary, here are the pivotal trials that were conducted of hormonal treatment intensification for metastatic hormone-sensitive prostate cancer. You all may have heard of some of these studies: Latitude, Stampede, Arches, Titan. These studies introduced drugs like abiraterone, enzalutamide, and apalutamide for patients that have hormone-sensitive disease. And one of the biggest questions has been, well, what about darolutamide? Darolutamide is an AR antagonist that doesn't cross the blood-brain barrier, seems to have a little bit more tolerable side effect profile from the standpoint of fatigue, cognition, falls, and its access right now has been really quite limited. It's not approved for castration-resistant disease if people don't have METs. It's approved in the hormone-sensitive setting, but only for people who are getting concurrent chemotherapy. So it's one of these drugs that sometimes is a little bit hard to get our hands on because of the indications of where it's been approved. But there were data presented from a study called Arano at ESMO. Go to the next slide. So this was a very simple study that took patients who had metastatic hormone-sensitive disease and randomized them to darolutamide ADT versus placebo ADT. This study was largely conducted outside of the United States with a primary endpoint of progression-free survival, meaning delaying the time that somebody were to progress from their cancer. Go to the next slide. You can see the demographics of the patients that were enrolled on this trial. This trial really was enriched for individuals that had metastatic disease up front, that had more high volume disease. Around 10% of people had visceral metastases in organs, and it did include a heterogeneous patient population with a good portion of patients who were Asian or Black. Next slide. This was a positive trial. It resulted in a statistically significant improvement in radiographic progression-free survival. If we look at the 2-year landmark, people who got ADT darolutamide, 70% of them were still alive and progression-free 2 years into therapy when they had high-risk metastatic disease up front compared to just ADT alone. And I think the other thing that I want to highlight is just, the ADT alone arm patients, they're not doing great, compared to the darolutamide with ADT. So again, this is the notion of treatment intensification matters in metastatic hormone-sensitive disease, and people can never catch up from an overall survival standpoint when they don't get intensified up front. So let's go to the next slide. We can see this is sort of the subgroup analysis. Across every single subgroup, we're seeing a benefit. There isn't one group that doesn't seem to derive benefit compared to just ADT alone. So again, speaking to the fact that treatment intensification is important, and darolutamide can achieve that very nicely. Next slide. And then when we look at side effects, and I think this is what's relevant for you all in the room too, is that darolutamide seems to be pretty well tolerated. It doesn't really add too much toxicity when just using ADT alone. And the rates of treatment discontinuation were actually higher in the placebo arm than they were in the darolutamide arm. And the rates of significant toxicity were similar between the two arms, and one arm was getting placebo and one arm was getting an active drug. So I think this drug is a pretty well tolerated agent. And my hope is that with additional data from a study being conducted in the US, that this would be something that the FDA would come to a determination about and expand the label so that you all can have access to this drug in the metastatic hormone sensitive setting, and it doesn't have to be linked to chemo. Next slide. And again, these are side effects of the drug. The other thing that we need to think about is because the patients on darolutamide lived much longer than the patients that were on ADT, they were on therapy longer. We sort of have to adjust the time that they were on treatment because, if somebody's on treatment longer, they have a higher likelihood of, having an adverse events documented. For example, if you're coming into the clinic over a 1-year period still on a agent, you have 1 year's worth of time to capture, oh, I'm experiencing this, I'm experiencing that. Whereas if the therapy is only working for 3 months, there's only a 3-month period to capture how people are feeling. But I think all in all, I think the side effect profile is fairly manageable with this agent and not too far off from ADT alone. Next slide. And then again, this is the secondary endpoints, overall survival, MCRPC, PSA, all of that looks good. Let's go to the next slide. Again, additional secondary endpoints, time to resistance, time to pain progression, all of that seems better with darolutamide. Next slide. And this is the PSA data. So this is people hitting a PSA of less than 0.2 anytime during treatment when they get intensified with this agent, 62.6% with darolutamide ADT compared to ADT alone. Next slide. So this is the study that I highlighted, the ARISEN study. This is the initial study that led to darolutamide entering into the hormone-sensitive setting, but this study linked treatment to docetaxel. So people who were getting ADT docetaxel plus darolutamide did better compared to people getting ADT docetaxel. So the difference between the ARANOTE study is it takes away the chemo. Next slide. And then here's the data. Again, when we compare to the backbone of ADT docetaxel, in every situation, adding darolutamide improves outcomes. So for those people that are getting, ADT dosi, I think in my practice, I'm not using that regimen really at all by itself for hormone-sensitive disease. I think if I'm using ADT dosi, I'm usually using it with an oral agent as well. Next slide. We can kind of skip through this. This is the toxicity data comparing the ADT chemo DARA compared to ADT chemo. And you can see that the two arms there's not too much difference from a side effect profile with the addition of darolutamide. Like darolutamide is a fairly well-tolerated agent. Next slide. This is the data from piece 1. So all of the information that I just highlighted was with the oral agent darolutamide, which is an AR antagonist. There's also plenty of data for abiraterone in this setting. Abiraterone and darolutamide have not been compared head to head, nor do I think they will ever be, just from the way that we do trials. But this study looked at ADT or standard of care with or without abiraterone. And we can go to the next slide. In essence, I know this is pretty complicated data, but in essence, the addition of abiraterone to the backbone of ADT with or without chemotherapy improved outcomes. And what was another interesting piece of this study was that they also used radiation to the primary for patients who present with metastatic disease up front. And for those individuals who present with metastatic disease at the time of their diagnosis and still have their prostate intact and it hasn't been treated, and they've got low volume disease, radiating the prostate dramatically improves radiographic progression-free survival and the risk of a serious genitourinary event, whether that be needing a urinary catheter or nephrostomy tube or TURP or other procedures. So for those individuals that are newly diagnosed with prostate cancer and it's spread already and it's low volume, meaning limited number of spots, treating the primary does improve outcomes. Next slide. All right, we're going to shift to metastatic castration-resistant disease and highlight some of the advances there. So largely when we think about metastatic castration-resistant disease, we're really breaking it down by, well, what kind of therapies has that patient seen prior? What did they see in the metastatic hormone-sensitive setting? Did they see ABI? Did they see DOSI? Did they see ENZA? What agents did they see? And what they saw previously guides what to select next. For those individuals that have received no prior docetaxel and no prior hormonal therapy, either abiraterone, enzalutamide, or docetaxel could be considered. For those individuals that have progression on prior docetaxel and haven't seen hormone, they can either get abiraterone or enzalutamide or cabazitaxel, which is a different kind of chemotherapy. And again, this is kind of for individuals that don't have any genomic alterations. And I am a huge proponent of genetic testing throughout the course of prostate cancer treatment. both hereditary testing and testing the tumor tissue, and doing blood testing serially along the way. I think it's really important to do that. Next slide. So this is data from piece 3. This data are, this is groundbreaking data. This is data that's going to change practice for some individuals with prostate cancer. This data was presented during the presidential plenary session at the ESMO meeting. And this was a large phase 3 trial that evaluated the role of enzalutamide with radium versus enzalutamide alone. Now, this trial is a little bit different because when it was designed, we were not intensifying therapy for hormone-sensitive disease. So the patients who went on this trial, this was a trial for hormone-resistant patients that had already progressed on their hormonal therapy. These patients didn't get intensified in the metastatic hormone-sensitive setting. So in my practice, not to say I don't encounter these patients, usually we're intensifying in the metastatic hormone-sensitive setting because, like I said, you just can never catch up. But if there happens to be an individual who, for some reason, was not intensified in the hormonal sensitive setting and had only received ADT alone and has bone mets, this trial is significant for them. So this trial randomized patients to, again, ADT, enzalutamide with radium versus enzalutamide alone. Radium is a naked alpha particle. So it's not a targeted radiopharmaceutical like Pluvicto is or some of these other agents. It's a naked alpha particle. It goes where there's calcium turnover in the bone. It targets the bone microenvironment and kills tumor cells that are in the bone predominantly. It doesn't really treat disease outside of the bone. And the primary endpoint for this study was rPFS. We go to the next slide. And we can see the proportion of patients, about a third of patients had received prior docetaxel. Very few number of patients had received prior hormonal therapy in the context of this study, okay? But you can see that about half of the patients had a lot of bone metastases, over 10 bone metastases that were seen on their imaging. And these patients didn't necessarily have to have symptomatic disease. Sometimes when we think of radium, we think of it as predominantly for people who have symptoms. These patients had no symptoms or minimal symptoms, as long as they had spots in their bones. Next slide. So this study was a positive study, resulting in a statistically significant improvement in rPFS in the time to progression with the combination of enza and radium versus enza alone. And what's also really interesting is actually we see that translate into overall survival benefit. Now, the overall survival data are still a little immature. We're waiting for that data to get more mature over time. But you could see that the curves are separating and they continue to widen over time. And the degree of survival benefit is even greater than the degree of rPFS benefit. There's about a 7-month difference in overall survival. That doesn't necessarily mean that it's only 7 months. That's just more of understanding statistics for the trial. All right, next slide. And then when we look at the subgroup analyses, the point estimate for benefit is really for every single subgroup. There doesn't seem to be a subgroup that doesn't derive benefit from the combination of enza radium. Next slide. And then other secondary endpoints that were looked at were time to next systemic treatment, which was also delayed in the enza radium arm. And I will highlight that about 85% of patients on this regimen were also receiving a bone protecting agent. We can go to the next slide. And this is time to pain progression. It's about similar actually between the two groups here. Next slide. And this is the skeletal related event data. And like I said, about 85% of patients in both arms were receiving a bone targeting agent, whether that be denosumab or Zometa. And I think there's been a lot of kind of mixed messaging about the utilization of these agents in the clinic. And these data really actually highlight that it's really important if people have hormone-resistant disease and they have bone metastases, that they should be on a bone-protecting agent unless they've got a contraindication for that agent. I think we definitely improve patients' symptomatic skeletal events, fractures to the bone, radiation to the bone, cord compression, needing surgery to the bone. I think we utilize some of these agents. Next slide. And then here's the safety data. I think a little bit more toxicity that we see with the combination. But, not to say not dramatic, about a 10% difference in grade 3 or higher toxicity that was seen. No deaths related to treatment at all that were seen. That was drug related, I should say. Next slide. If you want to go to the next, yeah, there we go. So then here's the data on like the adverse events of special interest. The big things we look at, hypertension that can occur, but it's about the same in both arms. There can be some fatigue, 5%, 1.8%, fracture, 5% compared to 1.3%. So these are the things to watch out for: anemia, neutropenia. This is the top part is all grade, meaning I should say all attribution, meaning it could be related to treatment, may not be related to treatment. And then the bottom part is treatment related. So sometimes people may experience things and we don't know if it is or isn't related to treatment, or if it's related to disease or related to some other drug or an infection or something like that. So sometimes when people are in trials, we clarify whether things are suspected to be treatment related or not. Next slide. So I'm going to close with this little bit of an overview about some clinical trials that may be relevant to you. And I do want to make sure we have plenty of time for questions from you all in the room. So I'm going to go through these 6 studies here, and we can chat a little bit about them and go through your questions. So the first study is a study called Neptune. This is a study for individuals that have newly diagnosed localized high-risk prostate cancer. We're learning that about 8% of patients that present with localized high-risk disease actually are born with a genetic mutation to predispose them for cancer. BRCA1, BRCA2, you all may be familiar with that. It's the same gene that actually causes breast cancer in women that causes prostate cancer in men. It's kind of a misnomer. There's been a big movement to try to change the name of this gene because it's not just breast cancer and ovarian cancer, it's also prostate and pancreatic cancer. But nonetheless, for individuals that have high-risk disease that's localized, they absolutely should undergo hereditary testing. And for those individuals that are positive, we're doing a study looking at the combination of olaparib with hormonal therapy given for 6 months prior to surgery. Olaparib is a very, very effective agent for people that have BRCA1/2 mutations. This drug is actually already approved in breast cancer for localized disease because it improves outcomes. And we in the prostate cancer world are about a decade behind the breast cancer field. It's already approved in late stage disease. This study is asking the question, why are we waiting to give this drug later when we know patients have a biomarker and they could respond to it and we can increase their cure rate? So this is something for those individuals with localized disease. I think everybody in the room who's high risk and beyond should undergo genetic testing, hereditary testing. The next study that I'll highlight is a study called Canopy. It's a phase 2 study of nivolumab and cabozantinib for patients with metastatic castration-resistant disease. Now, these 2 drugs, nivolumab is an immunotherapy to treat prostate cancer, and cabozantinib is a targeted therapy that treats the vascular makeup of the tumor. It actually inhibits blood vessel growth and formation within the tumor. And this is a non-chemo, non-hormonal therapy strategy. So I think for a lot of men who have advanced disease, later stage disease, I think this provides a novel mechanism of action that isn't chemotherapy and isn't hormonal therapy. And the treatment is given, the cabozantinib is given orally on a continuous basis. The nivolumab is given IV every 4 weeks. And when patients are on this study, they undergo very close observation. They're getting scans every 2 cycles, make sure that things are working and responding. And so the other thing about this trial is it is enrolling people that have neuroendocrine differentiation or have a tumor that's transformed. So I think that continues to be an unmet need in late stage disease, and this could be an option. The other study that I'll highlight is a phase 1/2 study of ARV-766. This is a androgen receptor PROTAC. So what that is, inside each cell, there's a system that gets rid of kind of old or mucked up proteins. Each cell has a garbage disposal with a mechanism to kind of clean up the old proteins or not needed proteins that are inside the cell. So this drug flags the androgen receptor, which we know causes prostate cancer progression and basically is the fuel in prostate cancer. It flags the androgen receptor to be degraded in the garbage disposal system of the cell. So, like drugs like abiraterone take away testosterone, so it doesn't bind to the androgen receptor. Drugs like darolutamide and enzalutamide block the androgen receptor, so it doesn't work. This drug binds the androgen receptor and puts it in the garbage disposal. And it's an oral agent with very minimal toxicity. And it seems to be pretty well tolerated in the clinic. And actually, Novartis bought the production rights for this agent from this small biotech called Arvinas. So it's going to be entering into phase 3, but we actually have the phase 1/2 still open at our institution. It seems to work exceptionally well for people who have mutations in their androgen receptor. And so this could be something to consider. I know that you all have heard a lot about testosterone therapy. I'll go to the next slide, the next trial here. Back up one, the next study called Step Up. So we are doing a study of bipolar testosterone therapy with Sam Denmead, who I believe has spoken to your group previously. He's a great collaborator and friend, looking at high-dose testosterone for people who have castration-resistant disease. Now, there's a very select population of patients to go on this trial. They need to have not seen chemo, minimal burden of disease. On this trial, patients are randomized to one of 3 arms, either enzalutamide or cyclic dosing of the testosterone. So patients will do like 2 months on, 2 months off, 2 months on, 2 months off. And we will adjust their treatment based on what their PSA and scans are doing. And then the other arm is PSA adaptive dosing, meaning we put them on the testosterone, we monitor their PSA. If their PSA goes up, then we institute the enzalutamide. We monitor the PSA when the PSA go down. And if it starts to rise again, we give them testosterone again. So it's based off of PSA response. So there's 3 arms on this study. So that could be an option. The last 2 studies that I'll highlight are not yet open, though they will be opening very soon. The Converge-01 study, I know there's been a lot of excitement around actinium and different forms of radioligand therapy. This is actinium alpha-emitting PSMA J591. It's a monoclonal antibody that targets PSMA, and instead of a beta emitter, it's an alpha emitter with actinium. This will probably be open sometime over the next couple of months at our institution. And then the last study is PREDICT. This is a phase 2 study that uses DNA and RNA biomarkers to select patients to appropriate therapy. So it's based off of the genomic profile in the tumor. Based off of what that tumor shows, patients will either get randomized to a EZH2 inhibitor, a specific kind of chemotherapy, and we will be actually slating in the Arvinas agent probably in the first or second quarter of 2025. So this is sort of what's in the pike. We can go to the next slide for the conclusions. Lot of really awesome things happening in prostate cancer. Be on the lookout for how Decipher testing is going to change treatment selection for hormone-sensitive disease. My hope is over the next year, we'll get darolutamide officially approved for metastatic hormone-sensitive disease without the link to chemo. There's going to be studies looking at early radioligand therapy that'll likely change what we do. Triple therapy is an option for patients with MCRPC now with Enza. and radium with ADT, like we discussed, and that has demonstrated delayed time to radiographic progression, and hopefully overall survival will be forthcoming. So I'll stop there, open it up for questions in the last 15 minutes or so.
All right, excellent. First, let's start off with a round of applause for the presentation. Thank you, Dr. McKay.
Of course, my pleasure. I kind of want to turn my video back on, but I'm afraid I'm gonna get bumped off again, so I'm just gonna keep it off.
Okay, yeah. The new auditorium is excellent in the way of the audio system, so you should be able to hear people in the audience, but just jump right in if you're not able to hear somebody, ask them to speak up. I'll point to whoever, raise your hands if you have a question. I'll point to each person. Please just speak up.
Is there any progress in immunotherapy research?
Do you hear the question?
I did. Is there any progress in immunotherapy research? Yes, there is. There's been a lot of progress. I think there's a lot of different kinds of immunotherapies in prostate cancer. One is just the checkpoint inhibitors. I think we're finding that an unselected strategy that doesn't include combination is not the way to go with just standard checkpoint inhibitors, but there are other strategies that combine immunotherapy. For example, Canopy is a combination immunotherapy strategy. There's other what we call bispecifics. There are bispecific antibodies that target a protein on the T cell, and they also target a protein on the cancer cell that are being tested. You all may have heard of AMG 509, which is a STEAP1 targeting bispecific. There's also PSMA targeting bispecifics. And these are sort of what they try to do is basically get the prostate cell in proximity to the T cell so the T cell can do what it's supposed to do and kill the foreign prostate cancer cell, basically. So there's been a lot of progress, I think, in that regard. We're not totally there yet, but still a lot of progress. Every person with metastatic prostate cancer should be tested to see if they have MSI high or high tumor burden. It's probably about 1 to 2% of all prostate cancer cases, but those individuals that do have such an alteration do amazingly well with immunotherapy. I have several individuals who've received immunotherapy. Many of them are in a deep remission for years with immunotherapy when they have that genetic alteration. So everybody should be tested for it.
Excellent. Next question. Stephen.
Yes, I was on the Step Up clinical trial, and I just got kicked off because I had progression under the testosterone phase. And I'm wondering, what do you do with patients after they get kicked out of the trial like that? Do they go on to another trial? Right now I'm back on insulin.
Yeah. Thank you for your question. And first off, I want to say thank you for participating in the trial. I do think trials offer patients the treatments of tomorrow today. So I think it all depends on what's going on with your unique case. You know, where are the metastases? What kind of treatments have you received before? To basically kind of go through what your options are. You know, I'm pretty systematic in the clinic when I see patients and they're progressing. We always go through, okay, these are your standard of care options that I can prescribe to you right now. Most standard of care options, they can be prescribed at any time. These are your off-label options that we could try to get that make sense. And then these are the clinical trials that you could potentially be eligible for. And then we decide based off of what's going on with any given patient, what they should receive or not, and what path they should go down. You know, the type of progression that they have, their burden of disease, the number of sites, I think matters. I will say we didn't talk too much about this, but I do integrate a lot of SBRT in my practice, spot radiation therapy. If people are on a given therapy, they're doing great, and they've got one area or two areas that are progressing, and they're the only sites of disease, a lot of times we may radiate those spots and just continue them on their original systemic therapy just to prolong the time and delay the time needing to switch treatment. So I hope that answered your question. But there's a lot of clinical trials after Step Up that you could potentially be eligible for.
Next question.
Are the bone metastases cells caused by prostate cancer the same as bone cancer cells from another?
Did you hear that?
I did. I was asking the question about, are the bone metastases that are caused by prostate cancer from the prostate cancer or another source? You know, they are generally from the prostate cancer. This isn't two cancers like prostate cancer and bone cancer. It's prostate cancer that's spread to the bone. Now, what I will say is, like, the prostate cancer that a lot of individuals are originally diagnosed with is not necessarily the prostate cancer that they have when they're progressing. There's evolution that happens in the tumor based off of various selective pressures that are imposed on that tumor and that tumor's ability to kind of, overcome various therapies. You know, I tell a lot of my patients that your prostate cancer is kind of like a gumball machine, and you've got a lot of tumors that are different. You know, not every single tumor has exactly the same makeup or exactly the same mutational profile. And even when we do the genetic testing, we don't necessarily know which tumors have which mutations per se. We don't know things at the single cell level, though I think there's tremendous amount of work being done to try to dissect things that are happening at the single cell level. So that's why resistance develops in prostate cancer. If every single cell was the same exact cell and had the same exact genetic makeup, people would never progress on treatment. We would give them treatment, and then the cancer cells would die and they would never progress. But that's not the case. There's kind of a gumball phenomena that's happening where some cells, they're all a little bit different, and they all have slightly different sensitivities to the treatment that we give them. And that impacts our ability to effectively kill every single last cell. But to answer your question, yes, it's prostate cancer, but sometimes that prostate cancer can change or transform or acquire new mutations. And sometimes it makes sense to repeat a biopsy to confirm it's still adenocarcinoma and genetically the same, or do a blood test if a biopsy is not feasible.
And I'm sorry, I cut you off before you got the complete question out. Go ahead, continue.
Along the same line, is the standard for monitoring bone cancer same as metastases from prostate cancer cells, regardless of the source? Is the standard the same?
Yes and no. You know, I think, when you say bone cancer, I think sarcoma, so this is not sarcoma. This is, and to monitor sarcomas, we do use CT scans and bone scans, and we would not use PET imaging. So, but this is not sarcoma. When I think the likelihood of that is very, very low. And usually when people present with a bone sarcoma, they don't present with spots all over their bones. They have one primary tumor that's in one location, and that's the primary source. And so I would delink that.
But the monitoring standard for metastatic cancer from prostate cancer is bone scans.
And the PSMA scan.
I'm sorry, can you repeat that question?
The question I had was, is the standard for monitoring the metastases from prostate cancer bone scans? Is that the general standard?
Yes, it is the general standard. Now, there are situations where we do a PSMA PET scan, but PSMA PET scan is not used for disease monitoring. We don't even know how to interpret a PSMA PET scan for monitoring response to therapy. We don't know that changes in SUV, like how they matter and what the clear criteria are. We do PSMA PET scans to identify metastases at critical time points and to assess eligibility for Pluvicto. That's the indications for bone scan, for a PSMA PET. So it's people who have newly diagnosed disease that's localized, but maybe they're high risk. You want to make sure they don't have Mets. You do a PSMA PET. It's people who have a rising PSA after definitive treatment, and you're trying to find metastases, you do a PET. It's people who have resistant disease and you're trying to see if they're eligible for Pluvicto, you do a PET. Those are the three indications where a PET is absolutely warranted. For people that are on treatment and they're just being monitored, doing serial PETs is, not necessarily the standard of care. Sometimes there's rationale to do it, but it's not the standard of care because it's hard to interpret the results of an on-treatment PSMA PET scan.
Next question.
Okay.
So we have the mRNA vaccines for COVID, and I actually just participated in a trial for an mRNA vaccine for flu. Is there any chance, or is anybody doing research on?
Yes, there is, and it's coming in the localized setting, likely given adjuvant to surgery and potentially adjuvant to radiation. We are working on a study. It's not going to be something that's going to be in the metastatic setting. It's going to be probably conducted in a localized setting with a goal to cure people. That's how vaccines are used. So it is coming. It's actually being jointly developed through Merck and Moderna, but more to come on that.
Okay. Another question. This gentleman here.
Following up on the immune question, what happened to NCI's interest in a triple approach? For example, a checkpoint inhibitor, either ADT or radiation to increase the immune cell populations, and then the vaccine, for example, a PSMA vaccine, all with the idea of reducing toxicity.
Yeah, I think very good question. I think there's been a lot of studies that have investigated this abscopal effect of radiation, and there's probably more hand-waving about the abscopal effect than actually true data that it actually does in fact happen. So, I think there's still trials that are ongoing. I think there's just many studies that have reported out on looking at the abscopal effect haven't actually been able to demonstrate it. So I think it's still a moving target. I don't think we're there yet.
All right. Time for another? This lady here.
Yeah, we can do one more.
Okay.
How many metastases do you consider oblio-metastatic? And the second question is, if you have a genetic testing and there are no mutations, why would you retest for that?
So if I understand the question, it's about genetic testing and why you would retest if there's no mutations.
Yes, and also what you consider oblio-metastatic, how many metastases?
Okay, got it. Okay. So the first question about genetic testing is there's two kinds of genetic testing. There's testing you as the patient and testing every single cell in your body. We don't test every single cell, but it's the cells that you were born with, not necessarily your tumor cells. And then there's genetic testing on the tumor. So let's first start with the genetic testing on your normal cells, which is usually just done via a blood test where they test your white blood cells that are in circulation. And they check to see if you were born with something to predispose you for the cancer. That test can be done once and it doesn't need to be repeated, ensuring that the test that gets done is an appropriate test that covers the appropriate numbers of genes. Sometimes I see people having a test done and it's only BRCA1 and 2 and they didn't get an expanded panel. So you want to make sure that you get the appropriate panel, but that test is tested once and the results aren't really going to change. Like we don't need a retest for germline hereditary variants, okay? The likelihood of sometimes people may see a variant of uncertain significance that most of those variants of uncertain significance over 95% of the time are benign. Now, the second test is testing the tumor. And that's the test that needs to be repeated over time. You can test the tumor by testing tissue from either a biopsy or a surgery, or you can test the tumor from testing blood because the tumor can shed circulating tumor DNA into the bloodstream. And so, you know, sometimes people will have their very first genetic test done on their prostate biopsy like a decade ago. Well, your tumor, you know, a decade later, after various treatments and various things that have happened, may not necessarily have the same genetic makeup from a decade ago. And it may be worthwhile to repeat the test to see if there's acquired mutations because of just the tumor progressing. It's not the same tumor as before, it's progressing, it's resistant to various drugs. So in that setting, repeating the genetic testing is absolutely warranted and makes sense. It's always preferable to do tissue over blood because you miss things in the blood, but sometimes tumor is not, sometimes tissue is not feasible. So your second best is just testing the blood. Okay. Did that answer? Oh, the second question is oligometastatic disease. It's an evolving definition. In the SABRE-COMET trial, which was one of the biggest studies that enrolled pan-cancer patients, but a large number that had prostate cancer, the definition was 5, less than 5 or less. Okay. So I think in general, that's likely the right answer, you know, 5 or less. You know, the problem when we think of oligometastatic, the whole concept of oligometastatic is that we're catching the disease before it's spread to other parts. And if we increase the number of spots, if there's 6 spots that we see, 7 spots that we see, 10 spots that we see, the likelihood that there's also tumors that we don't see, microscopic disease, is significantly higher. And the likelihood that just spot radiation is going to control things is low. For us to see things on a scan, generally we need like 1 million cells. So if it takes 1 million cells to see a spot, imagine what we don't see. So that's why there's hesitancy around spot treatment for multifocal disease. Hopefully that answered your question.
I know we do have more questions, but we'll honor your time. Dr. McKay, thank you so much for
oh my gosh, of course.
Again, another wonderful presentation. And for those who had more questions, register for the UCSD Patient Summit, because I'm sure Dr. McKay will be there.
Absolutely. You know, Aaron, it may be worthwhile just to come back and just do a question and answer session. No talk, straight questions from the audience, just to ask me anything thing.
Oh, that would be fantastic.
I think you all would look, because I feel the talks are great, but I know the most profound, you know, take home is the questions, you know, so maybe we could set up something like that in the future.
That would be great.
And I know, and I know with Bill kind of moving away, if you all need help with trying to find speakers, you can always reach out to me. I'm more than happy to help you.
Excellent. Thank you so much.
Of course,
right.
My pleasure. Okay, you all have a wonderful afternoon.
All right, take care. Safe travels.
Bye-bye.
Bye-bye. All right. Well, thank you for attending, everyone. As usual, we will have a light lunch. Please, especially for you newcomers, talk to somebody. You know, even I see that my mentor here has shown up again. This gentleman was asking one of the questions. He was the guy that I walked up to at my first meeting and said, "Help me," and he certainly did. He has a wealth of information. So, you know, talk to somebody. Talk to, you know, ask questions. Enjoy, and see you next month.